Good afternoon, everyone. I'm Dr. Queenie S. Quinio, and I'm here to talk about gestational trophoblastic neoplasia. This is the outline of my discussion. About 3 weeks ago, I discussed with you about gestational trophoblastic disease, which is a term used to include tumors derived from the abnormal growth of trophoblasts. The lesions range from the benign to the malignant forms of the disease. Partial and complete mole comprises the benign form, while gestational trophoblastic neoplasia comprises the malignant group of trophoblastic diseases. It includes the more common invasive mole, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. Postmolar GTN is usually diagnosed by HCG surveillance without any presenting signs and symptoms. The following are the criteria for the diagnosis of postmolar GTN as defined by the International Federation of Gynecology and Obstetrics. First criteria is plateau, which means you have an increase or decrease of 10% HCG level lasting for 4 measurements over a period of 3 weeks or longer. Second criteria is a rise in HCG level for 3 weekly consecutive measurements or longer over a period of at least 2 weeks or more. And third criteria is when you have histologic diagnosis of choriocarcinoma. In Europe and North America, GTN, specifically choriocarcinoma, is reported to occur in 1 in 40,000 pregnancies. However, in Southeast Asia and Japan, choriocarcinoma is reported to occur in 3.3 to 9.2 in 40,000 pregnancies. Risk factors for GTN would include a previous hydatidiform mole and advanced maternal age. So how do we diagnose GTN? So GTN is diagnosed based on the clinical presentation, the serum HCG, and the ultrasound. Patients may present with any of the following signs and symptoms: vaginal bleeding, uterine enlargement, acute abdomen secondary to tumor perforation, and bleeding from metastatic sites. So one must search for the signs and symptoms pertaining to the site of metastasis. In the presence of a suspicious vaginal mass, a biopsy should not be done as hemorrhage from the biopsy site may ensue. Patients may present with signs and symptoms of respiratory distress or pulmonary insufficiency, indicative of pulmonary metastasis. Lateralizing neurologic signs may be evidence of CNS metastasis. Serum beta-HCG is a human chorionic gonadotrophin, is an excellent tumor marker for GTN, which reflects the tumor burden, and it is used not only for the diagnosis but also to monitor response to treatment. As we can recall, serum beta-HCG is a member of the glycoprotein hormone. They are heterodimers consisting of an alpha and a beta subunit, where the alpha subunit is similar to your LH, FSH, and TSH, whereas the beta subunit is unique and it differentiates your HCG from the other glycoprotein hormones. HCG is produced by the mitotically inactive but functional trophoblastic cells of the placenta and all gestational trophoblastic diseases. It is estimated that about 104 trophoblastic cells required to produce a serum level of 0.03 MIU per ml. Hormone is concentrated in the cyst fluid of molar tissue with a long circulating half-life of 48 hours. In normal viable pregnancy, it is the intact HCG which is predominantly and biologically active in the serum and urine, which rises exponentially in the first trimester, doubling every 48 hours, and to peak at about 10 weeks. There are 15 variants of HCG in the serum and urine, and of which 5 are naturally occurring. It is the regular intact HCG which is produced by your syncytial trophoblasts, while the hyperglycosylated HCG is produced by the cytotrophoblasts. Now, this is the predominant form of HCG in patients with GTN. So how do we test beta-HCG? So we make use of the competitive polyclonal anti-HCG beta radioimmunoassay, which is the gold standard for HCG testing. However, its disadvantage is that this would require a gamma counter, and a test is complex and time-consuming. Nowadays, the most appropriate alternative test for beta-HCG is by using your Siemens Immulite. This is an immunometric assay free from radioactivity, and this is a fast turnaround time. GTN can also be diagnosed through your ultrasound. Sonography has become an important diagnostic tool not only in confirming the diagnosis of GTN, but also in determining the degree of myometrial invasion. It can also detect recurrence and evaluate good response to chemotherapy. Color Doppler studies can define regions of increased vascularity representative of an invasive disease and enhance uterine perfusion. So once presented with all this, how will we manage these patients? So first, an initial evaluation should include workup for anemia, preeclampsia, electrolyte imbalance, infection, and hyperthyroidism. Next, a complete metastatic workup should be done. A chest X-ray is important. We have to remember that the pattern of metastatic spread is through the hematogenous route, and it is the lungs which is the most common site of metastasis. A chest CT scan should be done if you have a normal chest X-ray. Studies abroad show that a chest CT scan would show micrometastasis in about 40% of patients with presumed non-metastatic disease. Cranial CT scan is also requested in patients presenting with lateralizing signs and in those with a large-sized lung metastasis or having an aggregate of 3 cm or more, which may signify cranial metastasis. Whole abdomen ultrasound is also used to assess the liver and the rest of the abdominal organs for complete metastatic workup. All patients with gestational trophoblastic neoplasia should be staged and scored using the 2000 FIGO staging and the risk factor scoring system. It is the FIGO 2000 guideline which has not only standardized GTN classification worldwide, but also proposed a well-established diagnostic and therapeutic criteria, and it has standardized the risk factors for chemoresistance, highlighting patients who would benefit from an initial treatment with single agent, or on the contrary, signaling patients who should be initially treated with multiple agent chemotherapy. This is a table showing us the FIGO 2000 anatomic staging system. Stage 1 being confined to the uterus. Stage 2, the disease extends outside the uterus, but it is confined to the genital organs or in the pelvis. Stage 3, pulmonary metastasis. And Stage 4, metastasis to other sites such as the liver and the brain. The WHO prognostic scoring system defines or helps predict the possible resistance of the tumor to a single agent chemotherapy. The following are the prognostic factors used in this scoring system: age, antecedent pregnancy, interval in months, HCG titer, the size of the tumor, the site of metastasis, the number of metastases, and any prior history of chemotherapy. Patients with a score of less than 6 can always be treated with single-agent drug, while a score of more than 7 should receive multi-agent chemotherapy. A patient's stage and score is reported by allotting a Roman numeral to the stage and an Arabic numeral to the risk score, separated by a colon, such as this one: GTN stage 3 score of 8. Unlike other cancers, treatment can be started without histopathologic confirmation of the disease, especially in choriocarcinoma and invasive mode. So the management: chemotherapy is a cornerstone in the treatment of GTN based on FIGO staging and your prognostic scoring system. For the non-metastatic stage or stage 1 and the metastatic low-risk patients, stage 2, 3 score of less than 6, are given single-agent chemotherapy with methotrexate as the preferred drug due to its proven effectiveness and low cost and long-term safety, with a survival rate approaching 100%. Patients are given a 5-day regimen every 7 to 10 days. So this is the table showing us the regimens for the low-risk GTN. So the methotrexate can be given at 0.4 mg per kilogram per day IV or IM, not exceeding 25 mg per day daily for 5 days, and we have to repeat every 14 days. Dactinomycin can also be used with a dose of 10 to 12 microgram per kilogram or a 0.5 mg flat dose IV daily for 5 days, and we repeat this every 14 days. So for those patients with metastatic high risk and stage 4, patients should be started with multiple agent chemotherapy in the form of Emaco or etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. Stage 4 patients with brain metastasis are given high-dose Emaco with concomitant adjunctive treatment of radiotherapy or intrathecal chemotherapy. So in here, the methotrexate dose in the Emaco protocol is given at a higher dose to help the drug cross the blood-brain barrier, concomitant with your brain irradiation or intrathecal methotrexate. Intrathecal methotrexate will be given at a dose of 12.5 mg, and this can be given at the time of the CO when Emaco is used or with EPA in the EP-EMA regimen. So this is the dosage for each of the drugs for the Emaco regimen. So surgery and irradiation are adjunctive treatments in GTN. Adjuvant surgical procedures are done to remove a resistant or persistent focus, to decrease tumor burden in patients with limited metastatic disease, to control bleeding, to relieve bowel or urinary obstruction, and treat infection. Hysterectomy can be done as an adjunct to chemotherapy. So it may be done for women more than 35 years old and or with completed family size, for control of profuse uterine bleeding, if there is inability to repair a tumor perforation, or when there is drug resistance. Radiation has a limited role in GTN, except in the treatment of brain and liver metastasis. Although its efficacy compared with your intrathecal methotrexate is controversial, radiation has been employed in an effort to minimize hemorrhage, and it has a tumoricidal effect and should be administered concomitantly with chemotherapy. However, there were reports from Charing Cross Hospital in London that whole brain irradiation may lead to memory impairment and increase the risk of second malignancies. So ultra-high-risk GTN has been identified as any presentation of GTN that might be associated with early death within weeks of starting your chemotherapy or poor long-term survival. Features of ultra-high-risk GTN are indicative of high disease burden, including the FIGO prognostic score of more than 12. It is also associated with a higher frequency of resistance to methotrexate and etoposide. It may include the following features: suspected or histopathologic diagnosis of choriocarcinoma, multiple pulmonary metastasis or associated hemoptysis, brain metastasis, large volume liver metastasis, profuse vaginal bleeding, beta-HCG of more than 1 million, and if the interval since the last antecedent pregnancy is more than 2.8 years. For those with massive disease, standing with a standard chemotherapy may cause sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia, multiple organ failure, any or all of which can result in early death. To avoid this, the use of an initial gentle rather than full dose of chemotherapy has been used. Induction chemotherapy using etoposide at 100 mg per meter squared and cisplatin at 20 mg per meter squared given on days 1 and 2 and repeated weekly for 1 to 3 weeks before starting the normal chemotherapy. And this had appeared to have eliminated early deaths in one series and with one promising results now reported by others. Patients who relapse after their treatment or become resistant to drugs are given second-line or salvage chemotherapy with or without surgery. EPEMA is the first-line salvage therapy. These are also several regimens used as salvage therapy. And what is new would be the use of high-dose chemotherapy with an autologous bone marrow or stem cell transplant and immunotherapy with pembrolizumab. High-dose chemotherapy with autologous stem cell support has been reported to produce sustained complete responses. A retrospective study of 32 patients with refractory choriocarcinoma or poor prognosis PSTT or ETT reported a sustained complete response in 7 patients, with 13 of 32 patients remaining disease-free at the time of analysis. What about immunotherapy using pembrolizumab? So what is pembrolizumab? This is a monoclonal antibody that inhibits programmed cell death protein 1, which functions as a checkpoint protein for regulation of various immune cells, including T cells with potential anti-tumor activity. You have to remember that programmed death ligand 1 is strongly expressed by your GTN. So outcomes were recently reported for 4 patients, including 2 with metastatic choriocarcinoma and 2 with metastatic PSTT or mixed PSTT-ETT. All patients had high tumors with high levels of PD-L1 expression. Durable treatment to response to pembrolizumab was seen in 3 of the 4 patients. So consolidation therapy or cleanup courses are additional courses of chemotherapy given after a normal value of beta-HCG level was achieved. This is to reduce the risk of relapse and for cell kill when the tumor burden is more than 10 to the 5th power. So for low risk score, we give 2 cycles, and for the high risk, we give 3 cycles. Response to chemotherapy is based on serial serum HCG. Adequate response means you have one log fall HCG from the baseline or more than 50% fall from the baseline. Partial response is when you have an HCG fall less than half from the baseline. Plateau if you have less than 10% fall from the baseline or a rise from the baseline. Biochemical remission is when you have 3 consecutive normal beta HCG level. Resistance may mean 2 plateauing values or 1 rising weekly by serum HCG or appearance of a new metastasis. So upon completion of the required consolidation courses, the patient is seen regularly with the following recommendations. A complete history and PE is performed every follow-up. Serum beta HCG should be monitored monthly after treatment for 6 months, every 2 months for the next 6 months, every 3 months for the second year, and every 6 months thereafter. Serial chest X-ray must be done every year, while your transvaginal ultrasound should be done every 6 months. We have to avoid pregnancy during the first 2 years by giving a safe and effective form of contraception, may it be your low-dose combined OCT, your injectable progestins, and your implants. We avoid pregnancy during the first 2 years because pregnancy will interfere with monitoring of your HCG. Majority of GTN will relapse during the first year, and the risk of hormonal changes may lead to tumor growth and response and relapse. Therefore, we have to delay to allow time for the ova to undergo repair, decreasing the risk of abortion and congenital anomaly. There are 2 common complications seen after a completed chemotherapy. One is the risk of early menopause, and second is the risk of secondary tumors. So, the risk of early menopause is seen following a single-agent chemotherapy, which would bring forward the age of menopause to 1 year earlier, while the combination chemotherapy would bring forward the age of menopause by 3 years earlier. In 2015, there was a study comparing single-agent and combination chemotherapy with respect to menopause. So methotrexate folinic acid showed only a 1% incidence of menopause before 40 years old and a 7% incidence of menopause before 45 years old. However, in multi-drug regimen, such as your imaco, there is a 13% incidence of menopause at age 40 and 36% incidence of menopause at age of 45. Another complication associated with previous chemotherapy is the risk of development of secondary tumors. Secondary tumors such as leukemia, AML, oral and pharyngeal cancers, melanoma, and meningioma were reported to occur after increasing cycles of alkylating agents such as etoposide. The risk depends on the intensity and duration of chemotherapy and the type of agents used. There was a study comparing methotrexate and combination chemotherapy. Methotrexate has no substantial long-term effect, whereas combination chemotherapy, the risk increases with the use of your alkylating agents such as your etoposide. So patients with GTN can be advised that they can anticipate good cure rate. Low-risk GTN has a cure rate of nearly 100%, while the high-risk GTN has a cure rate of 80 to 90%, with an overall 5-year survival rate of 92.7%. Now, let us discuss each of the different histologic types of GTN. So we begin with invasive mole. Invasive mole is a tumor or tumor-like process invading the myometrium and characterized by trophoblastic hyperplasia and the persistence of placental villus structure. So we diagnose invasive mole through the 4 through the following: your clinical presentation, sonographic picture, beta HCG titer, and in some cases, a histopathologic examination. So most patients with invasive mole present with persistent vaginal bleeding even after a suction curettage for a hydatidiform mole was done. So within 6 months or less, as the villi tends to invade the myometrium. A pelvic examination will show an enlarged subinvoluted uterus. A small number of patients may present with an acute abdomen because of tumor perforation. Your invasive mole clinically will not present differently from choriocarcinoma and other GTN, as they will manifest with an elevated HCG level and may give rise to secondary lesions in the lungs and elsewhere. In some patients, the initial transvaginal ultrasound may show findings already consistent with invasive mole with an intrauterine mass. These are cystic spaces consistent with a dilated villi in hydatidiform mole invading the myometrium. On histopathologic diagnosis, the lesion is hemorrhagic with molar vesicles extending from the uterine cavity into the myometrium, either superficial or extending into the uterine serosa. Microscopically, the molar villi would invade the myometrium. The hydropic villi may not appear as swollen as villi in a non-invasive mole. So this is an example of a gross picture of your invasive mole, wherein the hemorrhagic mass is permeated half of the thickness of the myometrial wall. And the picture below is showing us the villus, the myometrium, and the villi invading the myometrium. So the management for invasive mole is chemotherapy, basing on the FIGO anatomic staging and WHO prognostic scoring. Usually, low-risk patients would respond to single-agent chemotherapy. You will have to have the same follow-up protocol with the other types of GTN. Now let's go to choriocarcinoma. So choriocarcinoma is the most common histologic type of GTN. It is diagnosed based on the following. They manifest with trophoblasts in the pre-villus stage and with an absent villi. They are preceded by hydatidiform mole in 50% of cases, abortion in 25%, normal pregnancy in 22.5%, and ectopic pregnancy in 2.5%. They may not be apparent immediately after causative pregnancy. This would also spread hematogenously, so lungs being the most common site at 95%, followed by the vagina, the vulva, the brain and the liver, and the kidney and spleen. So patients diagnosed with choriocarcinoma would present with vaginal bleeding or bleeding from metastatic sites. The serum HCG is always elevated, more than 100,000 MIU per ml. On ultrasound, this would show heterogeneous appearance with areas of necrosis and hemorrhage, which are typical of the tumor, thus showing a semi-solid mass. Color Doppler would show abundant vascularization with low vascular impedance. On biopsy, grossly, this would appear as irregular dark red mass with variable amounts of hemorrhage and necrosis. Microscopically, it would show the absence of your villi, chorionic villi, and the presence of biphasic pattern with central cores of mononuclear cytotrophoblast surrounded by rows of your multinucleated in situ trophoblasts. Tumor cells seen at the periphery of the lesion with hemorrhage and necrosis in the center. The gross and microscopic picture of choriocarcinoma may be altered, especially after several cycles have been given before hysterectomy was performed. Immunostaining may be done when a definitive diagnosis cannot be given, as only cytotrophoblasts and intermediate trophoblasts are, are predominant. So choriocarcinoma is strongly positive for HCG immunostain and may show focal areas of syncytial trophoblasts and intermediate trophoblasts. Choriocarcinoma would have a high Ki67 labeling index. So this is a marker of proliferative activity at more than 40% compared to your PSTT and ETT. Chemotherapy is a primary treatment with cure rates of more than 90%. Adjunctive surgery, particularly hysterectomy, when performed, will provide the histologic diagnosis. The recommended surveillance and follow-up of patients is similar with the other GTN. So placental site trophoblastic tumor is a rare form of GTN composed of neoplastic implantation site intermediate trophoblastic cells. They would represent a neoplastic transformation of these intermediate trophoblasts that normally play an important role in implantation. The incidence is 1 to 2% among all GTN, and approximately 300 cases were reported in the literature. The following would help us in the diagnosis of PSTT. Vaginal bleeding is the most common symptom of PSTT, or the patient may have amenorrhea of varying duration in 90% of cases or an asymmetric enlargement of the uterus. Because of its rarity and vague symptoms, PSTT is difficult to diagnose. It follows term delivery in 78% of cases, while the rest would arise after an abortion or molar pregnancy. 10 to 15% are malignant, and 15 to 20% mortality rate are reported. Metastasis to the lungs, the liver, abdominal cavity, and brain have been reported, and this may develop several years after the initial diagnosis. On ultrasound, they would appear as heterogeneous hyperechoic mass with multiple cystic spaces within the myometrium of an enlarged uterus. On color Doppler, both hypervascular and hypovascular forms of the disease have been described, but none are diagnostic of PSTT. So this is an ultrasound picture of your PSTT. Your serum HCG level in PSTT is relatively low compared with the large tumor size. The level is usually less than 2000 MIU per ml. Histopathologic examination, grossly, most are well circumscribed and polypoid, projecting into the uterine cavity, or may predominantly involve the myometrium. So on cut section, the mass would show focal areas of hemorrhage and necrosis with an almost full thickness myometrial involvement. PSTT microscopically is described to arise from mononuclear intermediate trophoblasts on the maternal side of the placental bed. The tumor cells have irregular nuclear membranes, hyperchromatic nuclei, and dense eosinophilic cytoplasm to amphophilic cytoplasm, and most tumors have low mitotic count, and the chorionic villi is absent. So this is the histopathologic picture. Individual PSTT cell would extensively infiltrate the endometrium and may perforate the uterine wall. It also displays extensive infiltration and replacement of blood vessel walls. PSTT secretes human placental lactogen, therefore it is positive with HPL immunostain. It also stains with your cytokeratin, epithelial membrane antigen, and inhibin. So remember, PSTT is diffusely and strongly positive for HPL and MELCAM, but focally or rarely positive for HCG. PSTT is associated with abnormal expression of cell cycle regulatory gene products, including your cyclines, cyclin-dependent kinases, but they will be negative for P63. For the management, they have to recognize and treat concomitant medical complications, and they should order for laboratories and metastatic workup. Hysterectomy is a treatment of choice for patients whose tumor is confined to the uterus, while for those patients with the lower FIGO stage and who desire preservation of fertility, local resection and curettage may be therapeutic. But if the uterine disease persists, hysterectomy is indicated. Metastatic PSTT can be unpredictable, aggressive, and difficult to treat even with extensive multimodal therapy. Methotrexate is treated aggressively with multi-drug EMACO. All patients with PSTT would require lifelong follow-up with serum beta-HCG. So again, follow-up is the same as the other types of your gestational trophoblastic neoplasia. Now let's go to the last type of GTN, the epithelioid trophoblastic tumor. This is composed of malignant trophoblast with differentiation towards the intermediate trophoblast of the chorionic levee and is distinct from your choriocarcinoma and PSTT. There are 94 reported cases of ETT in literature. ETT would occur from age 15 to 48. It has also been reported in postmenopausal women. And interestingly, the oldest in literature was a 66-year-old Filipina in the United States with a history of H-mold prior to presentation of ETT 17 years ago. So the most common presenting symptom is vaginal bleeding. Serum levels of beta-HCG are slightly elevated at less than 2,500 MIU per ml compared to your choriocarcinoma. Higher levels of beta-HCG have been reported in patients with tumor in the extrauterine site. ETT has a tendency to grow in the lower uterine segment and the cervix, and metastasis would be reported to the lungs, the liver, gallbladder, pancreas, kidney, spine, and vagina. So this is an ultrasound picture which is not specific for ETT. It can be seen as heterogeneous mass in the uterus, commonly seen in the lower uterine segment of the cervix. Grossly, the tumor may present as a solitary discrete uterine mass that usually invade the cervix and the myometrium. It could either be solid or cystic, with varying amounts of hemorrhage and necrosis. Microscopically, the tumor is composed of relatively uniform population of mononucleate intermediate trophoblastic cells, forming nests and solid masses. The cells would grow in nodular pattern and would resemble intermediate cells of the chorion levee, designating them as chorionic type intermediate trophoblasts. This is the histopath picture. So just remember, ETT would test positive for your P63 and negative for beta-HCG. So immunohistochemical staining, again, positive for P63 and cytokeratin 18 for your ETT and negative for HCG. Same management applies. However, surgery is a primary treatment for ETT, and due to its rarity, the biologic behavior has not been firmly established. All patients are staged using your FIGO staging for GTN. However, the WHO prognostic scoring system is not used. So it follows the same surveillance with the other GTN. So this is a table differentiating the clinical features between PSTT, ETT, and choriocarcinoma. So PSTT has a history of mole in 5 to 8% of cases, while ETT 14% of cases, and choriocarcinoma at 50% history of mole. The serum beta HCG for PSTT and ETT are less than 2,000, while that of choriocarcinoma is more than 10,000. Treatment for PSTT and ETT is surgery, while choriocarcinoma, chemotherapy can be given. What about the pathologic features of the three? So for PSTT, the cellular population is a monomorphic implantation site intermediate trophoblastic cell, whereas your ETT would be your monomorphic chorionic type intermediate trophoblastic cell. And choriocarcinoma, they are dimorphic. You have primitive previllous trophoblastic cells, but absent villi. On immunostaining, your PSTT would stain to HPL, while your ETT would stain to P63, and choriocarcinoma in HCG, with HCG staining. So the following are just differential diagnoses for GTN. So sometimes they mimic GTN. So we have the missed abortion, ectopic pregnancy, placental site nodule, exaggerated placental site, placenta accreta, placenta polyp, and arteriovenous malformation. So this is an algorithm again for the diagnosis and management of GTN. So we have to remember clinical history and physical examination, the serum beta HCG, and the imaging modality. So once you are given the impression of a GTN, you should refer this patient to a trophoblastic disease specialist. So you have to remember stage 1, low risk, stage 2 and 3, low risk. We give single agent chemotherapy with or without hysterectomy. For stage 2, 3, high risk, and stage 4, imaco with or without hysterectomy, irradiation, or intrathecal methotrexate. In summary, gestational trophoblastic neoplasia is a disease that burdens the young and the old. It is different from other types of malignancy because it is highly curable, with a cure rate close to 100%. A histologic diagnosis is not needed before institution of chemotherapy because of the presence of serum beta HCG, which is a very sensitive tumor marker for the disease. These are malignant lesions again that arise from your placental villus and extravillus trophoblasts. This would include invasive mole, choriocarcinoma, PSTT, and ETT. Each can perforate uterine wall, metastasize, and lead to death if left untreated. Patients are classified based on the FIGO staging and scoring system. Chemotherapy is the mainstay of treatment for invasive mole and choriocarcinoma, while surgery is recommended for PSTT and ETT. Immunostaining can also aid in the diagnosis, and surveillance should be done for proper monitoring of these patients. A thorough knowledge of GTN is needed, and awareness of presentation of these diseases will enable prompt diagnosis and management. So a prompt referral may be done for accurate staging, which will correspond to your appropriate chemotherapy, adjunctive treatment if needed, and eventual cure. This is my last slide. Thank you very much for listening. Advance Merry Christmas. Have a good day. Thank you.